Hello, and thank you for joining today's session in LHSN's Safer Care Accelerator webinar series. My name is Dee Dee Thompson, and I'm a policy fellow here at Imperial College's Institute for Global Health Innovation, and I lead on the LHSN program. So we're thrilled today to be joined by Sue Latchem and Dr. Mark Temple from the Royal College of Physicians, who will be talking to us about their work on the Future Hospital. Now I'd like to give a very brief introduction of our speakers and then hand it over directly to them. So Sue is the program lead for the Royal College of Physicians Future Hospital program and leads on implementing the Future Hospital Commission recommendations. Of course, both of you can interrupt me if I do anything wrong. She's a nurse and midwife by background and also operations director at the National Clinical Guidelines Center, one of the largest clinical guideline development organizations in the world. Mark is a consultant physician and nephrologist at the Heart of England Foundation Trust in Birmingham. And he's also an acute care fellow at the RCP, where he's focused on improving the delivery of acute medical care, and also chaired the Hospital Pathways Workstream of the Future Hospital Commission. So now, without further ado, I'd like to go ahead and hand it over to Mark.
Thank you, Dee Dee. I'd like to just lead off, and I'll say a little bit about the Future Hospital Commission, and then I'll hand over to Sue as time evolves. So in the second slide, just to provide some context for the Future Hospital Commission, which came out in September 2013, this was an important report in our view from the College of Physicians in September 2012, Hospitals on the Edge, and really describing, if you like, a perfect storm of pressures on acute medical services throughout the NHS, particularly focused in England. I've taken the bar graph on the right-hand panel from a report into funding for social services, but what I wanted to bring out there was in England, along with a lot of other developing countries, there is going to be in the region of a doubling of the very oldest age group cohort over 85 in the next 20 to 25 years. I've also put some statistics just at the lower panel of this slide. In England, currently 50% of people over the age of 60 have one or more chronic illnesses. There's been a 65% increase in admissions in patients over the age of 75 in the last decade, and that compares with a 31% increment in the normal adult age group. And age over 65 patients account for 70% of our bed days in the NHS. And another striking statistic, which always impacts on me when I look at it, is that 25% of all inpatients in NHS hospitals in England have dementia at any one time. It's also worth stating, and this is something that's known across the world, that the length of stay, if you're in an older age group over the age of 85 in an NHS hospital, it's about 4 times as long as the length of stay if you're an adult under the age of 65. So I've summarized some of those pressures that are in that RCP Hospitals on the Edge report on the right-hand panel, talked about changing patients and changing needs, also concern about quality and safety, that we're moving to a more fractured delivery of care, multiple beds, multiple team moves, moving between wards, multiple handovers between junior doctors as their junior doctors' hours are reduced, and real concerns from physicians about that. And if you speak to patients, one of the things that most stresses them is the fact that they get moved, often in the middle of the night, to another ward, to another team. There are particular concerns in the NHS about the standards of care out of hours and mortality if you're admitted at a weekend in terms of death during hospital admission subsequently or the subsequent 30 days. And Sir Robert Francis was a Queen's Counsel, a barrister, who did a detailed bit of work at a particular failing hospital in mid-Staffordshire, and there was a lot to learn from his report. Like other health systems, we also have a lot of constrained resource, and I've indicated that alongside increasing clinical demand. And if you talk to our junior doctors, and by junior doctors I mean doctors that are 4, 5, 6 years out from graduation, about a third of those feel that the way they work out of hours on call is unmanageable and unsustainable. And we have real problems in recruiting, particularly around emergency medicine, acute medicine, that is, physicians working the first or looking after patients the first 48 hours at the front door of medical problems and in elderly care. The left-hand panel is just to indicate, and I'm not going to go through it in any detail, that the same pressures are exerted on healthcare systems in Europe. This was a Euro summit on the future of hospital services held in the Netherlands last year. Moving on to our next slide, in terms of the future hospital and milestones along the way, I've indicated hospitals on the edge on the left hand, and as you evolve, if you like, the future hospital report came out 12 months later. In terms of where we feel we are going with that, it sort of heaped pressure on Sue and myself and other members of the Future Hospital program team to have this statement from the Lancet to say that the report was the most important statement about the future of British medicine for a generation. Very encouraging, but it also means what next? What are we going to move to? And that's what we're going to talk to about shortly, about the Future Hospital program, and to share the learning. The program is in effect putting the Future Hospital report and its principles into clinical practice. And to share the learning of that journey, we have set up a Future Hospital journal published by the College of Physicians in September 2014. So just over a year ago, we set up and launched our first 4 development sites aligned to principles of the Future Hospital journal. And we're also inviting from physicians and NHS staff colleagues, nursing staff, therapists, to any examples of innovation that are relevant to the journey and the direction of travel of the Future Hospital Commission, and that's the right-hand panel. So in the lower panel, I've already talked about the mid-staff's report by the barrister, Sir Robert Francis. I've mentioned the Lancet in the middle, but it's just giving you some sense of the timescale of what's happening nationally. And within the NHS, a really important report came out just after in October last year, which was plotting out the major policy drivers for the NHS at the 5-year forward view. And we'll mention that a little bit later. But I'm pleased to say that there's a huge amount of synergies in that report with the principles and the direction of travel from the Future Hospital Commission. On the right-hand side, Commission of Hospital Care for Frail Older People, linked very nicely with our development sites, which have a particular focus on best care for frail elderly. The reaction I've already indicated. Our Health Minister, who's in the middle and looking remarkably youthful, said that the report was bold and refreshing, and I think you can probably interpret that comment in one of 2 ways, but he was very positive, and when it was launched with the press in September 2014, we went on to have a parliamentary launch later that autumn, and many of the briefings by our Health Secretary of State for Health included references to the Future Hospital Commission. So the government have been briefed, they've taken it up, but there is, it has to find its way through a number of other policy pressures and financial pressures. So what does the Future Hospital Commission report cover? There were 5 particular work streams. I'm not going to work through all of these. It's more to give you a sort of an overview. I was the co-chair of the first work stream indicated here, Organisation of Medical Care and Teams, which effectively was looking at pathways through hospital care, through secondary and tertiary care. And I've indicated in purple, there are 3 particular, if you like, strap lines that we wanted to bring out in relation to direction and recommendations. Probably the one that shines through most from this report is care organised around the needs of patients. And that's truly around the needs of patients, not the needs of the organisation or the needs of staff. And bringing care close to home, moving away from specialist care just being delivered on the hospital side. How close can we get it? Can we get specialist care into patients' homes? Can we get it into nursing homes? Can we get it into primary care facilities? The other statement, which I think is really key to this report, was under the 3rd work stream, building a culture of compassion and respect, and that's valuing patient experience as much as outcome. So there has been a huge focus, as everyone is aware, on patient outcomes, hard outcomes and softer outcomes, mortality, complications, patients' quality and safety. What we're saying is actually patient experience of their care needs to be right up there, and we need to recognize that as one of the key things that we're seeking to deliver, the best possible experience for patients. Principles underlying the Future Hospital, and again, these are 11 key principles that are in the report, and I would recommend to people, if they're not familiar with the report, to go and look at it and dip into it, and there are links from this presentation to the report and to the executive summary if you can't wade through all 190 pages. And again, I'm not going to go through all 11 principles. I have picked out 4 here: patient experience as important as clinical effectiveness, which I've already mentioned; ward hospital transfer only as necessary for clinical care; robust arrangements for transferring of care in place. We removed the term discharge from the report because our feeling was that discharge implies that the hospital physicians no longer have any continuing responsibility for the patient. We prefer to use the term transfer of care, and we want to try and bring out in that there are continuing responsibilities for secondary care or specialist physicians for the patient, irrespective of where they are, albeit in hospital or albeit in the community. And care designed to facilitate self-care and health promotion. And I think that's perhaps one thing that we have not embedded as fully in the NHS as we should, the ability for patients with a certain amount of direction from healthcare staff to look after themselves and to know where to get help should there be a deterioration, and actually setting out a number of scenarios that the patient might encounter post transfer out of hospital, and who to seek in those various scenarios, and we don't do that very well. I'm going to hand over to Sue shortly, but just to say a little bit about the model of care in the Future Hospital Commission report. We focused very much on a medical division that had responsibility right across from secondary and tertiary care to primary care in the community, and that's the purpose of the diagram in the right-hand panel. The patient in the center, the patient is the focus of all our attention and all our efforts, and you can see that it spans to the right-hand side of the circle, the community, and to the left-hand side at the more specialist end of in-hospital care. We were seeking to have strong specialty and generalist care, and that's maybe something that will come up in discussion. So generalist physicians in secondary care providing acute care and making judgments about those patients who are presenting with illnesses that don't align with a single organ specialty, don't align all that well with cardiology or respiratory in isolation. They may well have illnesses that span several specialties. And here we feel that the generalist, and by generalist I'm including elderly care specialists, but also acute care physicians at the front end and general internal medicine specialists or internists as being really key to the care. And we're looking at a much more healthy balance in terms of a hierarchy between the specialist and the generalist and secondary care. We were seeking to identify gaps, vulnerable patients, patients with dementia and learning disability. And there are 2 other things I just want to bring out here. We wanted to head up the medical division, or we've made the recommendation that this new wider view medical division across hospital and community care is headed up by a chief of medicine and supported by a chief registrar. The post of chief registrar is to recognize that the expertise of our training doctors, our junior doctors, and by that a better term would be middle grade doctors. These are doctors 6, 7, 8 years out from graduation from medical school. They have enormous insights into safety in our clinical areas 24 hours a day because they're working on the floor 24 hours a day. They've got insights into handover, into rotas that work, and they have considerable insights, a lot more than I do as an older generation doctor around IT. We need to utilize that, and we need to give them a voice and a senior position, and that's the idea behind the chief registrar. So in terms of our commitment to patients, I've indicated here that patients are at the center of this report. So we have made commitments in the report that are explicit about patients moving beds. They only move on the basis of need. They don't move in the middle of the night, something that is particularly distressing to patients, unless that's absolutely urgently required and is of benefit to that particular patient. We've made commitments to patients about communication and ensuring that they know who's in charge of their care at every stage of the journey. And on leaving hospital and having their care transferred, ensuring that you know who to contact if you become unwell after you leave hospital. At this point, I'll hand over to Sue Latchem.
Okay, thanks, Mark. So the binoculars, what does the future hospital look like? I suppose if we had chance to think about it again. We might not call it the future hospital because it defines care within a set of walls that might not traditionally meet the needs of patients going forward. But I'm going to spend a little bit of time now talking about the programme of activity and implementation that the Royal College of Physicians has set up to support the implementation of the Future Hospital Commission recommendations. So, for those of you who can't, well, you can't actually see us, but in the top picture, I'm the around the table with blonde hair, but I'm particularly keen to point out the gentleman on the right at the bottom is Mark Temple, fighting with a Mr. Potato Head, which I will explain shortly. So the Future Hospital Programme has been set up, as I said, by the RCP with some core funding for 3 years to think about how we can take the Future Hospital Commission from page to practice. I lead a dedicated team of project staff working with clinical fellows to actually deliver change and quality improvement. And I would say one of the key things that we are is both internally and externally facing. A lot of the Commission recommendations were challenging recommendations, if I may say, for physicians, but for all other professional groups. So there's work to be done internally with our own college fellowship and membership, as well as with other professional groups. We are delivering our programme of activity by using skills and quality improvement, organisational change, and really, as Mark says, making the most of social media and marketing to try and get our message out there. So what are we doing? Well, pictures speak louder than words, and I'll just spend a little bit of time talking about some of these images that I'm showing you here. So Mark has already alluded several times to the fact that what makes perhaps the Future Hospital Commission one of the most unique documents in the health system is that it puts the patient at the heart of everything, all services. So the image on the left with what looks like a spaceship in the top is actually a council chamber at the Royal College of Physicians, but it was a workshop for patients about how we can involve them in research in terms of either clinical conditions or how health services are delivered. And it was a really vibrant, engaging day where patients were very keen to have their voice heard. It was a really good day. In turn, the top two left pictures are images of our development sites that Mark will come on to talk about later on. Multidisciplinary, as you can see, all working to implement Future Hospital Commission recommendations in practice. I talked a little bit more about being internally facing, and the image on the right is a Future Hospital version of beer pong, if I may say, where we were trying to get our own college staff membership and clinical membership to actually identify how they engaged with some of the principles, the patient principles in the Future Hospital Commission. And you can imagine what competitiveness came out there. The last year, in March, the Royal College of Physicians held its inaugural conference, I believe, and obviously the focus was very clearly around how we can deliver the future hospital. So we had a number of innovative presentations there where people were already delivering very good pieces of work around making the recommendations a reality. The reference to the web there is around our Emerging Partners Network, which will be an online hub, and I'll talk a little bit more about that in a moment. Okay, so the Future Hospital Programme has a number of work streams set up around the construction of the recommendations, and again, you will see by no accident that patients are involved and engaged with everything we do, but there is clinical leadership at the heart of everything. So I won't spend a great deal of time talking about the wheel. Suffice to say that the detail of the activity is in the text surrounding them, but it gives you an indication of the actual focus of our first year of activity, which has been wide and varied, and a lot of it supporting the work of the development sites, as I said, that Mark will come to in a minute. A lot of it internally facing to support the college and its membership to actually deliver the future hospital, and a lot of work to begin to develop quality improvement methodology and approach to change. So we have a number of other projects. Mark has already mentioned the Chief Registrar role that was defined in the Future Hospital Commission report, and we've about to start in April next year a pilot of that role with a leadership and development support programme attached to it, and 26 trusts in England are willing and excited to work with us, and we're particularly pleased with that because we know that trusts in the UK and England are under great pressure at the moment in terms of access to medical staff, but it does, I think, give us a great sense that people are wanting to work in different ways. They're wanting to learn new skills and take responsibility for quality improvement locally. We have, over the last 3 years, undertaken a whole work stream of activity that supports physicians to engage with patient service users in facilitating shared decision making. Probably not a traditional approach to the delivery of medicine or nursing, I might say. So we have had a number of key successes with that, particularly getting the shared decision making approach utilised in the clinical assessment of trainees. So they have given a scenario where they have to facilitate shared decision making as opposed to direct decisions. So that's a good success. We've just completed a piece of work around the transition of young adults and adolescents from paediatric to adult services. We recognise this as a particularly vulnerable group who fall through that gap. The Future Hospital Commission was keen to identify those vulnerable groups, and we've worked with the Royal College of Physicians Young Adults and Adolescents Steering Group and a clinical fellow to help us shape some recommendations about what generalist physicians can use to make the best of services for these groups. Word that's on everybody's lips, it seems, particularly in the UK, I'm not sure across the world, is integrated care, and that's about delivering health services in different ways outside of the traditional hospital buildings, in partnerships with patients and with primary care physicians as we describe them. We've undertaken a literature review, and we've come up with, identified some key themes of things that will need to change to enable physicians particularly to work in new ways, and that can be around education and training. It could be around understanding the way in which services are commissioned, but also about working in partnership with colleagues in primary care, so outside of the traditional secondary care setting. We are modelling some of that activity with a group in Oxford who are trying to set up an integrated diabetes care work stream, and that group are actually giving us some fascinating learning that illuminates these themes from the literature review, particularly in relation to working with commissioners, identifying a good return on investment, working in partnership with primary care physicians, and engaging patients in service design. I won't talk any more about the Chief Registrar, as I mentioned that earlier on. I'm going to hand you back now to Mark, because Mark will talk as the Clinical Fellow about the programme of activity we've set up with our first 4 development sites.
Thank you, Sue. So I'm just going to go through our first development sites and just give a little bit of clinical insight into the drivers of what's different in those sites and what we're supporting. First of all, it's helpful just to indicate what the requirements were to be a Future Hospital service improvement project site. And these, we went out to application in June of last year, and we appointed, we had a lot of interest. We appointed our first 4 development sites in last September and launched them then. So the requirements were, as I've indicated in the left-hand panel, that they're aligned with the principles of the Future Hospital Commission, which I indicated earlier. The patient is very much at the centre of the project, so that means that the patient is involved all the way through in terms of those sites that want to make an application, in terms of planning what they're going to do, as well as implementation and being involved in assessing the impact of service change. I mentioned the importance of patient experience, which is actually my second bullet, and that is at the core of evaluation, to follow through on the statement, the principle that patient experience is as important as outcome. And these are collaborative partnerships with the college and other national bodies. So I've indicated on the map of England and Wales, we have 3 English development sites and 1 in North Wales, which is the extreme left-hand one in the west at Betsy Cadwaladr. And moving on to the next map of the UK, I did indicate that there was a major new policy document from NHS England, which came out last year, the 5-year forward view. And they've taken a similar approach to us. They've set out a direction of travel, but they want to road test their particular focus of work, and you can see that these are under the banner of Vanguards. So Vanguards are new NHS England work, integrated primary and acute care services, multi-specialty provision in the community, and enhanced health at care homes. All three areas are absolutely aligned with what we want to do in the Future Hospital, but they're not being run by us. And you can see that there's a rash of dermatitis or dotitis that has broken out in England and Wales. Sadly, not any in Northern Ireland as yet, which is another area of our responsibility, but we hope that will come soon. So our Future Hospital development sites have been a little bit, if you like, edged out by the number of other dots from the NHS England work. We are going to be working closely with them, particularly around the quality of evaluation, because often I think the Achilles heel of road testing new clinical approaches, new care models, is how do you assess robustly the impact of that on patient care. One other thing to say is that we have some advantages comparing our sites with the NHS England ones. One of the key ones is using the network of the College of Physicians, 30,000 members and fellows of physicians who are not only delivering care and leading care delivery on a local base, but are also national leaders and regional leaders. And we have got that network to share our learning and also to try and engender new ways of working nationally. It's also worth saying that the other thing we have an advantage for us is a blueprint document, a set of principles as laid out in the Future Hospital Commission report. So just to talk through the development sites, Betsy Cadwaladr, which I talked about a little bit earlier, is in North Wales, based in Bangor, just beside Anglesey, the island that you can see at the top of the picture. And the aim here is to improve access to care for frail elderly patients in rural Wales. There is a particular problem in that part of Wales about the distances to the local hospital, the local secondary care facility. And here they've indicated very nicely that from the peninsula in the lower southwest of this particular picture to Bangor is a round trip of 80 miles or even more than that. By having a facility set up for telemedicine in a local primary care building, they've reduced that down to 30 miles road trip. So the idea is to link up the specialists with patients in the community and saving them a lot of time and stress and distance travelled when that may not be necessary. The Mid Yorkshire Hospitals group is looking at an older people assessment service as part of an acute care hub. The acute care hub is a integrated area for those patients who first come into hospital. It includes an assessment area, it includes acute medical beds, but it often also includes a high care area or a high dependency area, and ambulatory emergency care where patients come in and are assessed on the basis that they can remain in the community. So what the aim here is to greatly shorten the time from patients coming through the front door with a new illness that are frail and elderly, being identified as having markers of frailty and seeing an expert, an elderly care consultant, much earlier in the journey. We're seeking to get that down to a matter of hours from the front door, and that's what the Mid Yorkshire Hospital is focusing particularly on. Development Site 3 is Worthing Hospital. They're taking a slightly different view. What they're seeking to do is co-locate patient pathways that are ascribed to acute medicine, elderly care, but also including surgical pathways, and having a unified emergency floor and a dedicated emergency floor medical team to look after those patients. So they're getting away from, if you like, separate pathways, separate silos, separate groupings of medical staff, and working in a much more fluid way around the patient priorities and the acuity of illness of patients. And in that is embedded a frailty unit. One of the aspects here is if the surgeons, when they assess a patient that has come with a surgical question, is this a bowel obstruction, is this appendicitis, if they deem that they do not need to take a surgical intervention and that patient can go home, they're seeking the assistance of the physicians to make sure that that can be done safely. So they have seen a marked increment in the patients that are discharged within 12 to 24 hours of presenting on the Worthing emergency floor. And as I've indicated, all patients coming through the floor are guaranteed to have a consultant in acute medicine or elderly care seeing them for the bulk of the day. That's the period 12 hours up to 8 o'clock in the evening. So this perhaps puts the flesh on the bones. It gives you an indication of what the team look like in Worthing. And from left to right, it's a surgeon, an acute physician, hospital manager, a patient to represent or to be there at the centre of what we're doing, what we're planning, and a geriatrician. This is in the Dorchester Library of the College of Physicians in London. We don't often get surgeons in the Dorchester Library, but it was nice to see a surgeon in the College of Physicians on this occasion. And this is to give you an idea of how the Worthing emergency floor looks. Often looking at the geography, you can get a feel for the patient flow, and the patients flow into this through the entrance beside ambulatory care on the basis that by selecting those patients that are near the door, they're most likely to remain in the community and not be admitted to any other area. There is a high care area. We've termed that high care because it's somewhere between a level 1 and a level 2 area in terms of nurse staffing ratios. It's not quite a level 2 or high dependency unit. And the acute frailty unit you can see is right within that emergency floor. Development Site 4 is East Lancashire Hospitals in the north of England. And here they're looking at better quality services for frail elderly patients and delivering that care at home or close to home. And the patient in the right-hand panel picture at the top is actually being managed by a therapist at home. These are widely integrated care or integrated teams working in the community settings. And by widely, I mean not just therapists, community nurses and district nurses, primary care services, general practitioners, but also including mental health and social care. And really wrapping around those patients that have multiple needs, the right staff at the right time. There's also a lot of emphasis on stepping these patients up and stepping them down. So stepping up, rather than defaulting to hospital admission with an illness, it's can you manage this illness in the community with additional staff assessing and delivering care to the patient. And if the patient is admitted to hospital, and we need to recognize that any patient of any age deserves to go to hospital for an acute illness, and we shouldn't be denying that. But if they do need to be admitted to hospital, can we step them down from hospital much earlier than we normally would with a tailored support service of staff in the community?
Thanks, Mark. So Mark's nicely outlined for you the 4 initial development sites for the Future Hospital, but we are keen to maximise our learning about how people are doing this. We're also future focused, which doesn't surprise probably anybody listening here, because as much as the Future Hospital Commission report published in 2013, we recognise the world moves on apace, and while we stay true to our blueprint, we do acknowledge that the changes to the NHS England Vanguard programme that Mark alluded to earlier begin to impact on the way we like to do business, and rightly so. So this is just a slide to say that we're about to, or in the process of recruiting our next phase of Future Hospital development sites. And because of the real focus of integrated care and trying to get people cared for in the right place by the right physician or personnel at the right time, we're actually looking this time to identify sites who are working in those ways, perhaps with vulnerable groups, working across the health economy. So watch this space on the Future Hospital web pages, and you'll be able to see who we're working with very, very soon. So I just wanted to begin to wrap up our session now, in that Mark has mentioned the 30,000 Royal College of Physicians fellows and members who in essence will be our main target audience, but we are very keen to maximise our learning and share it broader than the college. And the focus of our programme is to, as I said right at the beginning, to take the report from page to practice. Talking a little bit about how we intend to do that, we want to work with a number of partners who are sharing their learning with us. And our intention is to host an electronic hub that we will use as our central dissemination vehicle. So we will use it to communicate stories of good practice, to communicate messages of what's working well, to communicate college messages, policy messages that might support physicians in working in new ways. We have an aspiration that it will stimulate debate. So online chat rooms, being able to sort of share some of the barriers and the levers about being able to work, probably much like the process we're engaged in today, to be able to hear from people at the coalface, working in clinical care, to hear some of the direct challenges that we may be able to respond to and able to provide support. The intention of it is, of course, to encourage and support wider uptake of the Future Hospital Commission recommendations. Moved on to our image of our Tell Us Your Story Future Hospital campaign. This is a really exciting piece of work for us. We're building a catalogue of case studies across the UK that are being published on the Future Hospital webpage that are showcasing the examples of innovative work that people are already undertaking. And we are structuring this case study approach, if you like, to try and identify some of the key learning, to motivate clinicians to do similar things, but also particularly outlining some of the levers and barriers to how they implemented their work locally. This we anticipate being a core part of our partners network. It's a reminder at this point that patient engagement is central to everything we do. It's every level, both within the programme, within the college, within our partners in projects. And I have to, this image here was just taken last week. We had a 1-year anniversary of our development site. So the image you can see here is the acute care physician from the Worthing Hospital working with 2 patients to define what the learning is about engaging with patients. And I can honestly say they hold us accountable for every step that we take, and rightly so. So we're coming on now to just a little bit of a reflection, which we promised as we close down this session, because we recognise that we're quite unique in terms of a national programme of implementation building on a national report, particularly from a college, a physician-led college and its membership. So this is what we're going to talk to you now. A year on, we have a vibrant programme of activity. We've got a dedicated team who are really enthusiastic at capturing examples of innovative practice, of looking at new and innovative and creative ways of sharing that information with colleagues.
So I'll come in here. Our second sort of reflection in terms of looking at our programme is the key importance of getting the evaluation right. Sue, do you want to focus on that?
We would say that a year on, our programme is really engaged and embedded as one of the key players with external stakeholders. That might be other colleges, the Royal College of GPs, other professional groups. We've made really strong links with the NHS England Vanguard programme that we've described earlier. And actually, I think, Mark, you'd probably agree that a lot of our learning in year one has been seen to influence how this programme is beginning to shape up its activity, particularly, I would say, in relation to some of the challenges that the Vanguard sites may experience. It's been our opportunity to maintain our focus that patients should be central to everything that we do. And we've been engaged to support them in their evaluation of their programme, having done some of that critical thinking up ahead.
This whole area is not without considerable challenges. And one of the challenges is ensuring that, having had so much support for the principles of the Future Hospital Commission and the outline of new ways of working, it's taking that into clinical practice. Our view has been that if we get the evaluation right, then we'll be able to convince a critical mass of colleagues, not just physicians, but healthcare staff, nursing staff, therapists, social workers, everyone, that this is something to get behind and that this is very much patient-centred. I think one of the other challenges is, like alongside every health service across the world, there's huge demand, and it's trying to finance high quality within a financial envelope. and here we are trying to get new ways of working up and running and evaluated when we don't have any particular funding stream to support that. So we're relying very much on goodwill of healthcare staff and patients to respond to our recommendations about doing things in different ways. There's also a comment about taking Future Hospital beyond the development sites. We see the development sites as our test beds to gather evidence, to convince others this is the way to go, and then to make this, if you like, mainstream. And one of the key aspects of this is to have expertise in quality improvement across every acute hospital in every health economy within England and UK, Wales, Northern Ireland. And we want to, on the back of our Chief Registrar posts that we are also road testing, we see them as champions for quality improvement and for driving quality. And of course, they will be the leaders of the future.
And just before we talk about what our vision for the future years of the Future Hospital Programme, I think we've given those constraints that Mark's just alluded, we are amazed at the passion and the ability to deliver that is happening. There is good practice happening now. People are working so hard in the NHS, and I'm sure they are across health systems across the world, but actually people want to make a change. They want to make a difference, and we are about capturing how that is beginning to look and shape.
So finally, I think I'll just go through this rapidly to provide some time for questions, really. But where are we going? By 2017, we would hope to have many more development sites in progress. We will also have the evidence coming through to make this a much wider movement, a social movement, if you like, that our president of the college focuses on. This is an active partnership, as we've described earlier. I think it's worth just saying that we would hope that the quality improvement angle, if we would move on the way of improving quality within the NHS, we would hope that we would see in the future Future Hospital innovators that may be doctors in training, maybe quite senior as doctors in training, and also we may well be looking towards franchising or a certain marking, a kite mark if you like, or some standard mark of a particular clinical facility that is following Future Hospital principles and improving patient experience in line with the Future Hospital Commission report. We'll end there, and over to you for questions. Thank you.
Great. Well, thank you so much for walking us through that. I know we're approaching time, but I think we have time for at least one or two questions. Given that we're all kind of creatures of habit, implementing any sort of large-scale change is not without its challenges. So I was wondering if you've received any sort of pushback from any of the staff at the development sites, and if so, how you've dealt with that.
I think the answer I would give to that was, and I think the Worthing emergency floor was a good example, but it's true of all 4 development sites. It's not so much pushback. I think they clearly understand what they're seeking to do in their clinical area, but there have been times that there's just been so much clinical pressure on busy clinicians, busy nursing staff, that they haven't been able to put in place the change in approach that they want for the patient. So things have gone on hold, if you like, for a period of a month or 6 weeks. And that was particularly true in December of last year. So it's not so much reacting against, it's just saying, we know we've got to do this, but we just can't do it at the moment.
I think for me, one of the real key learning things from year one is that the passion and energy is there. Sometimes organisational or contextual things get in the way, but one of the things that we have been able to do as a college is support the clinicians, particularly on the ground, in terms of accessing their chief of medicine or equivalent, the medical director, being able to use communication from our president to the chief executive, just to sort of keep that top level encouragement to allow people the space to undertake change. And to not lose sight of the importance of what it's delivering.
Absolutely. So I know that the entire talk has been fairly UK focused, obviously, since your work is focused here. But I think that the challenges that you've mentioned are universal. Looking at integrating care, looking at aging populations. So I was wondering if there were specific principles that you think are applicable across the board, no matter which country you're coming from, and sort of ending on the 2 or 3 key takeaways that you think people should have when thinking about designing care for the future.
I think my immediate reaction to that is to look at the areas of risk to patients. Those are of the greatest risk, and probably that is when care is being transferred. So patients moving from the community into hospital and moving from hospital back into the community. So I think that should be the focus, that what do you want when you move into hospital? Well, you want the absolute expert care for your particular presentation as early as possible. And obviously within the frail elderly pathway, then that's an elderly care physician, supporting by expertise within the team, particularly therapists and nursing staff. And I think you could get things really good in terms of the hospital pathway, but things could then fall apart on the transfer out of hospital. So you need to have, if you like, the services wrapped around the patient for that particular problem when they go back to the community. And I like the idea that a number of my elderly care physician colleagues talk about, is actually identifying patients that they know or should be under their care in the community when they're in hospital and pulling them through the system. And I think that in terms of quality and safety and knowing who's in charge is really valuable.
And I suppose just in terms of where people across the world are thinking about making change, one of the things we've been very keen to support our development sites is support through the process of change. And as part of that, we've recognised there are some key things that we need to understand and support them with, and we cannot emphasize the importance of staff well-being through a process of change. It's hard enough working in clinical practice now, trying to implement change in whatever area requires staff support. So we've done a lot of work with our development sites to maximise that and encourage them to consider their own well-being, but also to consider the context and the culture within which they are trying to influence change, so that they can give themselves the best opportunity to make the change and make it happen and make that change sustainable.
Well, I think that's the perfect note to end on. So I wanted to go ahead and thank all of you for joining, and especially thank Sue and Mark for taking the time to present to us today. As you can see, their contact information is listed on the screen in front of you, so please feel free to send through any additional questions. Also feel free to contact us at the LHSN team at lhsn@imperial.ac.uk. Thanks so much. Bye-bye.